Good afternoon, ladies and gentlemen. We'll be starting shortly. Thank you for joining us this afternoon. I can promise you it's going to be an exciting discussion. So I'll just stay tuned. Uh, yeah, so good afternoon, everybody, once again. This afternoon, we are going to be having a very interesting discussion on an approach to diabetes mellitus and pregnancy. My name is Dr. Alfso Damala, internal medicine consultant and endocrinology. And with me here is Dr. Dimos Atta,
a consultant in obstetrics and gynecology. You're all welcome to this edition of webinar.
Okay, so I strongly believe we're going to have a very interesting conversation this afternoon. It's 5:06 now, so it's 3:06 now. So I think we just give participants a few more minutes to join up. We have close to 40 people online now, so I think we'll just go about 2 or 3 more minutes before we start. So please stay tuned, and we're going to start shortly. But I promise you it's going to be valuable for your time this afternoon. Thank you very much. Okay, so Dr. Amos, what's your experience with managing patients with diabetes and pregnancy like?
Actually, diabetes mellitus is one of the commonest medical disorders in pregnancy. Management of diabetes mellitus in pregnancy is a requires multidisciplinary approach.
Right.
Actually, by the time you're able to carry the patient along, educate them, counsel them on what the disease entity is all about,
Right.
and you get their cooperation, many times you get a favorable outcome.
I totally, absolutely agree with you on that. So this afternoon, we'll try to follow this outline for the discussion. We'll just try to go through the elements. We'll make it as practical, as easy to follow as much as possible. Okay, so by the way of introduction, sorry, let me get this right. So by the way of introduction, we all know what diabetes is. A lot of things, different pathways, all of them culminate in an impairment of the body in handling carbohydrates, protein, and lipid. And of course, it leads to chronic high blood sugar because insulin is either not produced in adequate quantities, or it's not able to act well. More often, a combination of the two mechanisms. So, what makes GDM actually different is that, of course, the person is pregnant, and apparently the diabetes was not there before, and we think it's something related to the pregnancy that makes the glucose intolerance to happen. And traditionally, we used to define it as any degree of glucose intolerance with onset of first recognition during pregnancy. There's one funny thing that we note, that if someone has impaired fasting glucose before, borderline diabetes before, and the person becomes pregnant today, automatically the person the person already has some impairment in glucose tolerance in pregnancy. So it's important to talk about this because it has implications for the female population and, of course, implications for the mother and implications for the fetus as well. So the next question we need to ask ourselves is, next question we need to ask ourselves is the comparison of comparing GDM to the regular diabetes that we're used to managing. What do you think is the key difference between GDM and the regular diabetes that we manage?
Actually, the key difference between gestational diabetes mellitus and diabetes in pregnancy, just like you earlier stated, is any form of impairment in glucose, which is now identified either first recognized during the index pregnancy or in any way at any time during the course of pregnancy.
Right.
In some instances, some patients already have diabetes mellitus, but were never aware that they have diabetes mellitus
until
it wasn't diagnosed prior to conception.
And now they
now during the course of pregnancy, maybe we are contact with your doctor for one evaluation or the other. Diabetes, during evaluation, some investigations are requested based on the risk factors that perhaps the patient has and diagnosis of.
I'm sure you agree with me that it can be quite tricky to sometimes distinguish between a diabetes that predated pregnancy compared to the one that really started in pregnancy, especially in someone that does not have a history of diabetes before. So she has never checked, and the one comes to you at so time, and then you find the person having qualified for diabetes or gestational diabetes. What are the key things that can help you separate that this is likely a pre-gestational diabetes or gestational diabetes?
Actually, some key things that may help you to be able to distinguish them or separate them is mainly your risk factors. Sometimes you make use of some risk factors that will help you to know that, perhaps this very some of these risk factors may happen during this index pregnancy.
Absolutely.
Such as maybe perhaps presence of persistent glycosuria or even presence of infections such as folliculosis and pyelonephritis.
I think it's also important that in GDM, usually the glucose intolerance usually happens from mid-trimester upwards, so from 24 weeks. So it is also thought that if we see someone that's having dysglycemia, for example, in the first few weeks of pregnancy, it's just a bit less likely
that it predates pregnancy.
Absolutely, absolutely. So let's talk about this case review. So there's the one we saw a while ago, a 31-year-old primary gravid person, a banker. She presented at 36 weeks gestational age, and she complained that she was not feeling fetal movements anymore over the last 36 hours. She reported that she did an antenatal clinic elsewhere, and she came to Abuja for business and actually to deliver as well. Weight was 103 kg, and BMI was 32 kilogram per meter square. And she reported that she did not do a glucose test earlier in pregnancy because she did not have any problem. She was fine, and it was a normal pregnancy as far as she's concerned. Unfortunately, the ultrasound confirmed that the woman, there was no fetal sound, and we have intrauterine fetal death. And at that point, they did a random blood glucose that came out to be 178 milligrams per DL. That would translate to roughly maybe 10 millimoles
per liter.
Also, what do you make out of this case? Just briefly.
Yeah. Actually, for this very index patient, we all know that hyperglycemia can be very harmful to the fetus, especially when it's not diagnosed and controlled properly. Like for this very index patient who moved to Abuja, most likely there has been a persistent hyperglycemia, which she has never been aware of. And that has caused the catastrophe of intrauterine fetal death, which was noticed in this very index patient.
And I'll say that this is perhaps one of the most feared complications of gestational diabetes or diabetes in pregnancy. So I think it will do us, it will worth our time to actually engage in this discussion so we can rub minds together and hopefully can improve our practice and the way we care for our patients who have diabetes in pregnancy. So as a matter of introduction, we know that this is a public health priority, it's a maternal priority, and it doesn't have implications just on now. It has impact on the future burden of non-communicable diseases because, like we say, these women, they have a higher risk of type 2 diabetes later in life. They also have a high risk of other cardiovascular disease, and of course the fetus itself also has a high risk of diabetes, obesity, and other issues later in life. So unfortunately, the burden is increasing because we know that diabetes is happening at an earlier age, and we know that females, ladies are sometimes giving birth in advanced age because
career,
to other issues of my career,
education.
Absolutely, absolutely. And of course, we also know that the incidence of being overweight or obese is increasing as well with westernization, especially even among the women of reproductive age. So it's perhaps no surprise that the burden of this is actually on the rise. And some people have quoted that GDM occurs in about 3 to 4% of pregnancies. We have our own figures here in Nigeria, and we can see a wide duration of figures being reported. What do you think may be responsible for this extent of duration? We have about 1% being reported in Abuja at some point, and up to as high as 23% in some streets in Lagos.
Actually, various factors can be adduced to for the gap in the prevalence rate across the various regions. One is the diagnostic criteria used in making your diagnosis for the gestational diabetes mellitus. Secondly, the ethnicity. We know that among the ethnic groups across the various geopolitical zones, there are some ethnic groups that perhaps may be more predisposed to diabetes mellitus in pregnancy. And also, we know that perhaps in the rural area where there's no modification in maybe diet, compared to the urban areas where we've seen increasingly westernization of our diet and sedentary lifestyle setting in. So perhaps that may be one of the reasons why there's this disparity across the various regions.
Absolutely. So it's important to know that amongst people who have diabetes in pregnancy, about 90% is gestational. Okay, so vast majority of diabetes you see or dysglycemia you see in pregnancy is gestational, and there's only a small fraction that is pre-gestational. And it's interesting in the audit they did in the UK that a lot of their CS were actually due to diabetes, so which is interesting. So this is a reminder on the way we classify diabetes. I believe we all know this. We have type 1 diabetes, we have type 2 diabetes, we have other specific type of diabetes, which is a broad group that encompasses about perhaps almost 40 etiologies of diabetes. And then of course we now have the gestational diabetes. But in pregnancy, the way we classify it is either this person has a diabetes that genuinely started in pregnancy, which is the gestational diabetes, or
the one that predates the pregnancy.
Which is typically type 1 or type 2, but can also be any of the other types of diabetes, including steroid-induced, MODY, and all of the rest. So it's important to put these classifications in our mind as we go into the discussion. So this chart here shows us the part of the pathophysiology of gestational diabetes, and we know that the pregnancy hormones are actually central to the development of increased insulin resistance we have in pregnancy. So we have growth hormone, cortisol, prolactin, human placental lactogen. And insulin resistance tends to increase, particularly from second trimester upwards, okay? And a normal person, so to say, will actually increase their own insulin secretion to overcome this resistance and will tend to maintain euglycemia, okay? So if you're able to give a compensatory increase in your insulin secretion, you have the normal glycemia throughout pregnancy. But in many people, they are unable to mount that increment in insulin secretion, which is actually related to the pathogenesis of type 2 diabetes itself. Absolutely. So that is just broadly part of the pathophysiology. And this chart here shows us the insulin requirement during pregnancy. It's important to note, can I get my highlighter here? So it's important to note that So it's important to note that the amount of insulin that a person requires in pregnancy, in fact, indeed, in first trimester, the insulin sensitivity actually gets better. You can see that speaking up here about 8 weeks, insulin sensitivity gets better, okay? And then the insulin requirements gradually increases, particularly from about 24 weeks, and peaks close to term, slightly gets better, but basically insulin requirements increases. But a normal person is actually able to maintain euglycemia through all this. Now, there are a lot of changes that happen in the fetus as well, and the way the fetus actually responds to the glycemia of the mother. So we have this chart here. Dr. Amos, can you run us through this?
Okay, actually, looking at the chart, The fetus is a wonderful parasite. In the presence of hyperglycemia in the mother, there is transfer of glucose to the baby through the placenta, and this stimulates the Langerhans cells in the pancreas, in the fetal pancreas, to also produce insulin. This insulin that is being produced causes, there is hyperglycemia in the fetus, stimulating production of fetal insulin. This insulinemia causes the absorption of the nutrients, the hyperglycemia, into some of the anabolism. Build up. Anabolism is a process that is very oxygen demanding, causes oxygen consumption. And when there's fetal hypoxia, it can cause either stillbirth or even stimulate erythropoietin production, leading to polycythemia, and at the end of the day, causing sludge in the blood cells. And that is one of the things that have been implicated in intrauterine fetal death. Because when there's sludging, there's hypoxemia with sludging, it can occlude blood vessels, and that can cause fetal death. Also, we know that some of the tissues, especially within the central area, such as the pancreas, the liver, the spleen, and the heart, and the muscles, they are very sensitive to insulin. And as such, there's absorption of this glucose into this tissue, causing hyperplasia of this very tissue. And that is why for the fetus, they can have cardiomegaly, and also because of this absorption of glucose into the muscle, these fetus are prone to have developing fetal macrosomia. And also, we know that hyperglycemia also can suppress the synthesis of surfactants in this baby, thereby making this fetus prone to respiratory distress syndrome.
Just like the classic hyaline membrane disease. Absolutely. So it's important to know those changes happen in the mother and the baby. And of course, all of those things actually underlie the reason why we give all the interventions we give to a pregnant woman who has diabetes. Now, talking about the risk factors for gestational diabetes, what are the risk factors of gestational diabetes?
Actually, risk factors for gestational diabetes mellitus ranges from advanced maternal age, usually greater than 35 years of age, obesity, usually with a BMI greater than 30 kilograms per meter square. However, for BMI, we would like to use BMI that is within the first trimester, because with advanced gestational age, we know that there's a big contribution from the fetal weight.
Fetal weight and the amniotic fluid
as well. Also, we can use a gross weight of greater than 90 kilograms or excessive weight gain greater than 15 kilograms during the course of the pregnancy.
So that means the case we discussed earlier, that was about 103 kg. It means some of the red flags already.
Yes, already for gestational diabetes mellitus.
Are there particular ethnic groups that are more prone in Nigeria? Do you have data on that?
Actually, I don't have data for now.
Okay, but we know that certain ethnic groups are more prone, particularly in the US, the African American women and the Latinos.
Also, prior history of gestational diabetes mellitus and persistent glycosuria, just like we mentioned earlier. History of unexplained IUFD, like the index patient that was discussed earlier on, and previous history of fetal macrosomia, or even recurrent fetal losses, or presence of congenital anomalies, previous congenital anomalies. Also, it's a risk factor.
So if you get any patient that's reported that I had a child that has also congenital anomaly, is a child that you want to make sure that you're not dealing with
subsequent pregnancy, such candidates, such guests should be evaluated for pregnancy.
Particularly screen at first contact. We'll talk about screening along the line. Okay, so of course, here on this slide, we also have family history of diabetes. Unfortunately, in Nigeria, many people don't know their family history. Polyhydramnios in instant index pregnancy. I've seen actually many GDM patients that is the polyhydramnios that treat the attention of the sonologist and make them
further.
Absolutely. So of course, recurrent infections, particularly UTI and CO, previous GDM, multifetal pregnancy, preeclampsia.
Previous history of PCOS.
Absolutely. So we know that PCOS is strongly associated with insulin resistance. And of course, anything that causes some extent of insulin resistance increases the chances of having of GDM. Okay, so how do we diagnose? How do you diagnose someone with dysglycemia in pregnancy? Of course, for someone that has diabetes before, he or she had diabetes before pregnancy, so that one is not coming for any new diagnosis. But for gestational diabetes, or some that will look like gestational diabetes, that will now eventually say that this is actually like a pre-gestational. But for gestation, how do we make a diagnosis of these patients?
Actually, diagnosis of gestational diabetes mellitus in pregnancy, it entails taking a detailed history.
Right.
Just like we mentioned, there are some risk factors that you look out for.
Right.
And by the time you have those risk factors, such patient is a candidate for you to screen for presence of gestational diabetes.
So that would be like a selective screening, right?
Yes, selective screening.
Just screening people that have certain risk factors. But some people also do universal screening. That is, no matter what, whether you have 0 risk or 1 risk, or once you enter their clinic, you're going to be screened for.
Actually,
which of the approaches you?
Actually, like in America, they go for universal screening, which they screen every pregnant woman that comes to the clinic. But however, in Europe and even in our environment, we usually utilize the selective screening.
You know, in US, the obesity rate is very high. And I had one of the professors in one of the centers there, and she said that, by the time you use the BMI criteria, almost all of them fit into it. So they have a lot of obesity. Well, I think I agree with you that selective is probably more pragmatic, focusing on people that have more risk factors, and then we do that. Okay. Now, should people be screened in early pregnancy, or should we actually wait till mid-trimester before we screen them?
Actually, for those ones that already have obvious risk factors, it's good you can institute your screening as early as possible.
Absolutely.
However, for those ones that doesn't have obvious risk factors, you can wait till 24 to 28 weeks where you institute your screening.
There's a person I saw once, and then she was screened around 24 to 28 weeks, and the glucose was really very high. And she was trying to blame the healthcare workers that why wasn't screened earlier. And then I told her that, well, number one, that this glucose is just likely going up now. This is when its immune resistance tends to go up. And then, so eventually she saw reason with it. And funny enough, it's possible that if you screen that earlier, it will have been normal, actually. It will have been normal. Now, talking about the 1-step compared to 2-step screening, can you just tell us about the 1 and 2-step screening briefly? Okay, the 1-step screening is what usually is even advocated by the World Health Organization, where you subject these women to 75 grams glucose. You give them an insert 75 glucose after a fasting blood sugar is taken. And afterwards, you now do a 1 hour and 2 hour blood sampling to be able to evaluate them. And there's already a cutoff point that beyond that, you'll be able to make a diagnosis of gestational diabetes. So is it better than a 2-step screening?
Actually, studies have shown that there's no more difference, actually, because the 3-step screening, when you look at it, especially for our environment, it is capital intensive, especially in our environment, it's very costly, and especially in our environment where many of the women are not even captured by the National Health Insurance Scheme. So it's studies have shown that there's no remarkable difference in the outcome, and as such, in our environment, we institute the 1-step screening.
Absolutely. So it's not so useful to do fasting blood glucose only to screen for diabetes in pregnancy. Now, in some high-risk people, you could just do that at first contact, but you're screening for pre-gestational diabetes like that, because GDM is predominantly a postprandial issue. So it's important to know that. And there are many cutoffs, but I think most of the cutoffs are now, they're getting closer to each other. They're not so far.
Trying to harmonize.
They're trying to harmonize many of them so that we have less chaos. Okay, so we've talked about this selective screening earlier, and I think we've talked about the risk factors that should make us want to particularly screen somebody. Now, talking about the cutoff that is used in establishing a diagnosis of gestational diabetes particularly, most of the things we know are actually from the APO study, that's the hyperglycemia and pregnancy outcome study, which we did study about 25,000 people, and they try to check the amount of their blood glucose fasting 1 hour, 2 hours after food, and they see how high it is, and they categorize them into several categories. But one of the key things we learned from it is that the higher the blood glucose you get in a pregnant woman, the worse the pregnancy outcomes. In fact, there's no sharp threshold in which, so it's a strong and continuous relationship. And we can see from this chart on the screen, I think it's not likely very clear. Okay, but the first A is birth weight above 90th percentile. Here we have primary cesarean section, that is the first cesarean section occurring just because related for issues related to that pregnancy, hypoglycemia and umbilical cord C-peptide levels. All of these parameters actually increases the more you're having the
glucose
level in the mother, and that means we should actually aim for the lowest values possible without incurring an unnecessary risk of hypoglycemia or any morbidity. So those are the ways you get the cutoff for. And it's important we talk about this. That is, in people that you test, so you did an OGTT for somebody, and the fasting in the OGTT is 8. In fact, a good laboratory will not go ahead to give the person the glucose drink again because it already met. Okay, so but if you meet the gross criteria for diabetes mellitus, you should diagnose that rather than calling it gestational diabetes. And we should not miss word for the woman, trying to let her feel that it's a pregnancy that caused this. And that's not likely necessarily related to the pregnancy. Yes, the pregnancy could have exacerbated it or made it worse, okay, but that's just overt diabetes, okay?
Yes.
The extent of dysglycemia in GDM is subtle, it's not very gross, and usually it doesn't usually meet the criteria for of diabetes traditionally. We've talked about it earlier that the onset of GDM is usually in the 2nd to 3rd trimester when the glucose, when the insulin resistance increases. Remember, we talked about this graph earlier. I'll just show us again here. So we can see here that from about the 24, 28 weeks thereabouts is when the
peak influence of the diabetogenic hormones of pregnancy.
Thank you very much. You said it explicitly. Okay, so going forward now, we have this chart that shows the cutoff from different studies. Here in our center, we use the IAD PSG criteria predominantly, and the cutoffs are shown on the screen. So you have a fasting greater than 5.1, or 1 hour greater than 10, or 2 hours greater than 8.5. Any. It was like a single figure, a single digit. So crossing to 8.6 or crossing to 5.3 establishes a diagnosis of GDM. And it's important to do this because we are saving lives when we do this. Many people try to want to have a tendency of that, well, it's just small, or it's just small, that used to be above it. That small is one that will persist and will increase our pregnancy negative outcomes. Absolutely. So we also have the Carpenter and Costin criteria. We have the NICE UK criteria. And what I said, the most widely used are perhaps the first two, the high DPH and the Carpenter and Costin. And it's what is used predominantly by the ACOG, the American and the American Diabetes Association. So we should not forget that if any of the test parameters miss the criteria for overt diabetes, we should diagnose as such, and that we don't use the term pre-diabetes or impaired fasting glucose or glucose intolerance in pregnancy. Any degree of glucose intolerance in pregnancy is diabetes mellitus in pregnancy. Not just for the sake of the mother, but also for the sake of the baby as well. So we have these different categories of diagnosis. Should we talk about it?
Just like you said earlier on, there are some that predates the pregnancy.
Absolutely.
And that is the one we term as the pre-gestational diabetes mellitus. And there are some that are newly diagnosed during the course of pregnancy. Those ones can see maybe they are already diabetes mellitus, but they were never aware that they had diabetes mellitus. But because they are now pregnant, based on the value, after you've done your screening and you've done your diagnostic test, based on the value, you can now tell them to be newly diagnosed diabetes mellitus.
I want to emphasize on that, on what's on this slide there, that in people that have newly diagnosed diabetes in pregnancy, there's no role for lifestyle dietary modification alone at all. You need to initiate pharmacotherapy. Why? Because the degree of dysglycemia here for you to diagnose DM in pregnancy is overt. That is, we're talking of a fasting greater than 126. We're talking of 2 hours post OGTT or postprandial greater than about 200. And I mean, that is highly phytotoxic.
You need to
start it straight away without wasting any time. And of course, sometimes, maybe a bit rarely, we see all these diabetes emergencies in pregnancy. I've probably managed about between 10 and 20, okay, but they're not that common. So DKA, HONK, some of them actually newly diagnosed, but invariably those ones are actually
emergency cases.
The emergency cases, and they are usually overt diabetes. It's not just the GDM. Of course, we should also remember that the so-called euglycemic decay is more likely to happen in pregnancy than outside pregnancy. Okay, so we have these categories in pregnancy. On the lighter note, This is a picture of our cardiac catheterization laboratory. That's our cardiac physiologist operating the cath lab, the C-arm of the cath lab machine. And of course, we have the invasive hemodynamic monitors here. On this side here, I'm not sure you can see my highlights, but this is our defibrillator, which we use to, in case we have tachyarrhythmias and co. So it's just interesting being in a cath lab sometimes. I go there from time to time just to observe what they're doing. Okay, so now how should we evaluate patient presenting with gestational diabetes?
Actually, evaluation entails taking a detailed history from this very patient.
And we tend to gloss over that sometimes.
Yes, we tend to overlook that very aspect. We need to take a detailed history,
right? And
from the history, you'll be able to talk about, other risk factors, because even those ones that have gestational diabetes mellitus, there are some instances that they have other comorbidities,
right,
such as hypertensive disorders,
right,
and other things. So you take a detailed history, then you come down to your obstetric history. You want to know when they saw their menses last, so that you'll be able to date the pregnancy properly, because it will also go a long way in the way you're going to manage this very patient. Dietary history is very important, and also their lifestyle history. You want to know how is their lifestyle, because at the end of the day, you're going to put all those things into consideration.
Absolutely.
When you're going to manage them.
And you talked earlier about the pregnancy weight and the rates at which you gain weight in pregnancy. Many of the GTMs I've seen, actually someone I saw sometime last week, the amount of weight, I didn't think our weight was that much before. We should weigh about maybe 85 or something. But our pregnancy weight was about maybe just 62 or 63. So she told me that, and she showed me a picture. I was like, wow. So rapid weight gain in pregnancy actually can be a red flag, and it's a very high risk factor for developing. The other thing is also important to ask about previous glucose tests. Somewhere like Abuja, like this, people actually check their sugars quite a bit, actually. And you see some people, they will say, well, my sugar, there was one time I got 7 point something, but it became normal afterwards. So it tells that this person likely already has. So we should take that, ask them whether they've done sugar tests before in the past, and then how was it? What kind of numbers did they get, if they remember? So that can be also helpful for us. Of course, there's a lot of biochemical evaluations, biological and biochemical evaluations to do blood pressure, urine, A1C to see the glycemic control, depending on where you're seeing them. Of course, interpreting A1C in pregnancy is different. I'll talk about it in the next slide. EUCR, endoscopy. It is said that retinopathy can worsen in pregnancy, people that have it already. And people that have some sort of advanced retinopathy or proliferative retinopathy, you should actually advise them to get it lasered or treated before they get pregnancy, ideally. But unfortunately, most of the people we see, I'm talking about pre-gestational diabetes now, most of the people we see don't have that issue so much. So, but in interpreting A1C in pregnancy, we know that A1C is usually slightly lower in pregnancy, and it's because of the increased red cell turnover and the volume expansion, which dilutes the A1C. But from many studies, we know that by the time someone's A1C in first trimester is greater than 5.5 or 5.7, according to some studies, the chances of having GDM, gestational diabetes, is very high, because it suggests that there is already some extent of glucose intolerance. Okay, and then at the time of diagnosing, if you get an A1C greater than 6.5, that already meets the diagnosis criteria for diabetes mellitus. So it suggests that the person likely actually has overt diabetes mellitus or pre-gestational diabetes mellitus. But otherwise, the role of A1C in managing and even diagnosing GDM is actually quite limited because of the nuances in the interpretation. And it's usually an adjunct to the self-monitoring of blood glucose. That is, the blood glucose monitoring at home is the primary tool by which you assess the efficacy of whatever treatment
management.
Thank you very much. Exactly. So, but the A1C can be used as an adjunct and can be done about maybe every 2 months if you need to do it for someone in pregnancy. So how do we manage these people? Okay, we've talked about them, now they're at our doorstep. Maybe you have that person that we said at IUFD at the beginning of the discussion, and you found out that the sugar is this level, maybe normalize after perhaps, okay, but now you have a pregnant again, and then the sugar is high enough for you to diagnose GTM. How should we approach these people? How should we manage them?
Actually, for management of gestational diabetes mellitus or diabetes mellitus, actually, it can be grouped into preconception care, intrapartum, antepartum, intrapartum, and postpartum care.
So that's about the preconception care.
The preconception care, even though it's not too popular in our environment, it is very key and very important because you tend to evaluate this patient, interact with them. One, the issue of contraception is very key because it's not, when the blood sugar control is not optimal,
right?
You have to counsel them to prevent conception until you're able to achieve a good control of the sugar level before embarking on conception. However, for those ones that are already planning for that meets the criteria to embark on conception, you need to review their drugs. Some of those drugs are embryotoxic, so you need to review their drugs. Absolutely. And some of them already have medical disorders such as hypertension. You also need to review their drugs, ensure that you are able to achieve good glycemic control before they're able to embark, before they get pregnant.
Absolutely.
And that is also when you also place them on folic acid, because we know that gestational diabetes is associated with congenital anomalies.
Absolutely.
So you place them on folic acid, preferably 3 to 6 months before conception. Wow. Yes, to prevent the incidence of congenital anomalies. And also try to manage them properly. Then the antepartum care is very important. One is a multidisciplinary approach to the care. One, we need the obstetrician, we need the endocrinologist, we need the dietitian, we need a diabetic nurse, and we also need even social workers in managing this patient, because by the time you're able to counsel this patient, involve all these people, many times the outcome may be most likely be favorable for this very patient. So you take a detailed history when they present to you in antenatal, when they come for booking, take your detailed history, you examine the patient properly, and just like we said, you carry out some basic investigations, your full blood count, your urine creatinine to evaluate the renal function. You also assess the liver function.
Right. Absolutely. Now, the multidisciplinary team is actually key, and I've seen many people with gestational diabetes that are just being managed by maybe just endocrinologist or just the obstetrician, which is not enough. So we should actually come together, and I think patients can be referred to centers or to be made to be managed in centers, like a high response, where these joint clinics are actually holding either together or at least in sync with each other. The diabetes education can also not be overrated, actually. Patients should see a nutritionist, which will give them individualized guidance to their diet. We know that out of every 10 people with GDM, about 6 can be managed successfully without pharmacology, without just diet and lifestyle modification. So it's very sensitive to diet. And when they just simply adjust their diet, you just see that their sugars just become better, like magic. Of course, there's a role for medications, there's a need for long-term monitoring. The monitoring perhaps is the most intense part of the treatment, because usually these women go from 0 to 100 and they have to be pricking themselves about 4 times every day. So, of course, there's a need for follow-up. In our clinic here, we see them every 2 weekly till delivery, actually, from diagnosis. And they need ongoing support. So usually they have to have the number here. We give them standardly the number of the doctor managing or the diabetes nurse so that they can call. Because usually when people like this go home on insulin, they have one challenge or the other. So they can call someone that, oh, this is like this, or I'm having this trouble. And they can get guidance to just help them troubleshoot and solve whatever day-to-day problem they have. Many times we miss out on the long-term care. That is after delivery. Actually, you don't see them again.
Some of them, you lost them to follow. And that is very important. And that is where your education becomes important. They need to be aware that they need to be followed up. Just like we said earlier on, there are long-term sequelae for both the mother and even for the baby.
Absolutely.
Some of them, studies have shown that up to 25 to 50% of these women go to develop overt diabetes mellitus later on in life.
So this is a beautiful baby, and it just reminds us that when we're managing women with diabetes in pregnancy, the ultimate aim, at least from the mother's point of view, is actually to have a healthy baby. So have a healthy baby. So An healthy baby is a priceless goal for them. This afternoon, I saw someone with triplets that still fairly healthy pregnancy, but she's going through stuff. She has medical complications of pregnancy, and she's just bearing everything, just doing that. Okay, so maybe that's you understand. So the highs of both us and the patient should actually be on making sure that the baby is healthy. And I think sometimes we leverage on this to get the patients to do what we need. So patients that will otherwise, they're not even willing to check once a day, but when they're doing it for their baby, they're willing to check 4 times a day, they're willing to use insulin, they're willing to come to the hospital now and then. And
the compliance will be better.
It's better, yes, because they know that they're doing it for their baby. So we've talked earlier about preconception care, and we're going to talk about antenatal care now. And I think we're going to talk about this other part along the line. So what are the key things we focus on in the first trimester?
In the first trimester, first we need to, just like we said, it's a multidisciplinary approach.
Absolutely.
We need to involve everybody, all disciplines for a favorable outcome. You need to date this pregnancy so that it will guide you how you manage this patient, and especially when to effect delivery. You need to date the pregnancy properly. Then you screen for diabetic complications and assess during the course of the antenatal, you ensure that you'll be able to maintain or achieve a good glucose level during the course of pregnancy. You also need to counsel them on symptoms of hypoglycemia. Even though they have problems with elevated sugar level, sometimes some of them do have hypoglycemia, especially some of them that are already on medication, they can tip into hypoglycemia. So you need to counsel them on symptoms of hypoglycemia or how to prevent hypoglycemia. In as much as hyperglycemia is dangerous, hypoglycemia is also very dangerous.
I absolutely agree with you, sir. So what are the key things we focus on in the second trimester now?
Yes, it's all about instituting close fetal surveillance. We know that in the second trimester, there's increased fetal growth. So you need to, each time they come, ensure that you do your fundal height and you correlate it with their gestational age to perhaps give you an idea if baby is growing properly, or perhaps if already complications such as fetal microsomia is setting in. But we should also be aware that it's not all the time that it's all about fetal microsomia. Sometimes there could be some vasculopathy and intrauterine growth restriction to set in. And during your surveillance, you'll be able to assess and be able to pick some of these complications. Also ensure that you, just like we said right from the first trimester, ensure optimization of the glycemic control and screen for other congenital anomalies. And that is where you can do your anomaly scan between gestational age of 18 weeks to 28 weeks. Just like we said, they are prone to either congenital heart defects and also neural tooth defects.
Absolutely. So what are in the third trimester? What are the key additional things to focus on in the third trimester?
Yes, in the third trimester, you need to also continue to ensure like good glycemic control, assess the fetal growth. And that's when you intensify, because in the third trimester, that is when complications can set in, such as sudden fetal death. And as such, anything from around 36 weeks or 34 weeks or 36 weeks, you need to increase your surveillance. You start doing your 2-weekly ultrasound scanning and even continuous CTG 2-weekly from 34 weeks, so that perhaps you'll be able to identify any complications that may set in.
Okay, thank you very much. So I'll just remind our audience that we can post our questions in the chat box or in the Q&A box. We'll answer the questions towards the end of the presentation. So let's just put our questions there, and then we'll do that. Of course, we know that at the end of the presentation, over the next few days, the slides will be sent to you, to the email you registered with. So please be rest assured about that. And let's focus on the presentation. So talking about the medical component of the management, which is a big part, okay? It involves medical nutrition therapy. Unfortunately, a lot of women struggle with this. Why do they struggle with this? They struggle with this because they have cravings in pregnancy, they think they're doing a lot of work and they deserve the treatment. But we'll go into that shortly. Because there's physical activity and lifestyle changes, which are different in pregnancy, because obviously when someone is pregnant, you can't tell the person to be skipping or to be doing something totally off like that. And of course, there's Need for glycemic monitoring, the targets in pregnancy are different. If for anybody that does not know, if you don't take anything away from the discussion today, you should remember that the targets of glucose management in pregnancy is very different from outside pregnancy. And if you mix them up, we're going to have very negative outcomes. And of course, we talk about how to start insulin and also oral agents and how to identify such. Of course, that's be an integrated care, that is multiplying management, like we said, and then managing the patient, the baby, even with the family as well. Of course, we will talk about the perinatal management, and I mentioned earlier that follow-up in pregnancy is 2 weekly through to the end of pregnancy, and that's because things can change so fast. So because the predominant abnormality in GDM is postprandial, it's actually quite sensitive to dietary changes. And I mentioned earlier that the vast majority of patients with GDM are actually controllable on dietary and lifestyle changes alone without requiring any form of pharmacological agents. The calorie should be controlled. We did mention earlier that the patient should have a session with the dietitian. And I think the dietitians actually know how to navigate, particularly with the nuances peculiar to pregnancy. So the woman will have her cravings, and then they'll be able to select some things that are relatively more healthy that she can use to satisfy her cravings while still eating healthy. Unfortunately, I've met a lot of people too that they had to make a lot of sacrifices regarding diet during pregnancy. Now, tell us that people that are not so overweight, is better to allow them to eat a almost normal diet and put them on insulin rather than for you to starve them too much and then they're not getting enough weight in pregnancy. So it's important to do that. And it's also important to avoid ketosis. The way you can know if your patient is developing ketosis by the time you're getting 2+ or more of ketones in the urine, you can tell you that your patient is in starvation mode and the person is actually starving himself to control, herself to control the glycemia. So, of course, exercise is also important. The exercise helps to mop up postprandial glycemia, and that's because of the skeletal muscle uptake is increased. The person moves around, particularly after food. Or the exercise we recommend for our patients should be appropriate to the pregnancy, the duration of pregnancy, and also to the how fit the woman is. So for most people, it's just taking some sort of walk or by doing some little house chores here and there that can suffice for some exercise for them. Now, while we mentioned that for most people that lifestyle modifications alone suffices, there is a tendency to not give medication to people that need because you are still watching one, or to delay unnecessarily, and it can be catastrophic sometimes. So it's important that we should be able to identify the people that need pharmacological intervention. So there are many approaches to it, but the approaches that we tend to follow here is close to that which is recommended by NICE UK, and that if there's overt hyperglycemia, by the time you're getting hyperglycemia that is overt, you're getting the fasting of maybe greater than 110, postprandial already greater than 140, 150. It's important to start medications appropriately if there's overt hyperglycemia. Secondly, like we mentioned earlier, if the person meets the threshold for diagnosing diabetes, which is very overt hyperglycemia again, please start medications immediately while you do lifestyle medications as well. Okay, but otherwise, for most people, which is a mild to moderate dysglycemia we see in GDM, monitoring on non-pharmacological therapy for the first 2 weeks is totally appropriate. And for the vast majority of people, you just see the numbers are controlled, and then you're good enough with that, and you continue with that. Sometimes through pregnancy, but sometimes it can change. Why? Because we said that the glucose insulin resistance increases as pregnancy progresses. Absolutely. So sometimes, so it's just subject to review. Okay. And we said that insulin is the first line for most patients. We're going to discuss along the line comparing insulin to the oral agent, but for most people, insulin is the preferred first line agent. And there are many regimens we can use. Basal bolus insulin regimen that is using thrice daily of pre-meal insulin with a basal insulin, or using a premixed insulin is the typical regimen that is used. But we should also know that some people in the Western countries that have access to CSII, that's a continuous insulin infusion, can actually do that as well. So in terms of the weight-based dosing, the total daily dose of insulin is usually in the range of what is written on the screen here, 0.7 to 1 point. But usually it's better to start on the low side and then titrate based on the patient's response of the patient. Absolutely. I will tell us that for most people, the twice daily premixed insulin regimen is more convenient, okay? But the basal bolus is more flexible, okay? And basal bolus is a preferred, but it usually involves 3 to 4 injections per day. Whereas the twice daily premix, they can get away with just a single type of insulin, and then they use it 2 times a day. Generally speaking, the insulin analogs like Aspart and Lispro, that's Novorapid or Humalog, they actually give us a better control with postprandial glycemia, and we tend to prefer them in pregnancy, even though you can also use the whole soluble or regular insulin as well. Okay, but the analogs actually gives us, it eats it better, and then it doesn't act for so long. So it gives us a better control of the postprandial glycemia. But traditionally, still the regular soluble insulin and NPH that is traditionally used. Okay, but the analogs, as I said, they profile particularly fit pregnancy, and they're also known to be safe in pregnancy. Now, we should know that not all insulin has safety data in pregnancy. So particularly glargine, that's Lantus insulin. We use it sometimes in pregnancy, okay, but they don't have data, at least last time I checked, compared to the other type of insulin. So now in terms of the way we start insulin in pregnancy, it's important to educate the patient on the diagnosis. We talked about that before, and of course on insulin therapy as well. Some people admit for this, which is fine, but sometimes you can have an extended diabetes education session with the patient on an outpatient basis, depending on your clinical setting. It's important the patient is educated on insulin use. Also, the patient should have the ability to monitor and interpret the data. Okay, so the person, for example, you cannot start insulin on someone that does not have a glucometer with gestational diabetes. No, then you have to get that first, learn how to check, learn how to interpret, and then you can now give the person and go with it. Okay, and that's why the education is very important. Now, for people that have, the approach can also depend on whether it's predominantly fasting or postprandial hyperglycemia we have. For GDM itself, it's predominantly postprandial you have. So you tend to see someone that has a fasting of 4.6, but the postprandial is getting to 8 point something, 10 point something. So it's predominantly postprandial spike. And so in people like that, most of the time we start them on the premix insulin. So if we start, for example, a biphasic insulin, you can use about 0.5 units per kg per day. So a 70 kg person using this will get about maybe 35 units, and you can give it in 2 divided doses. But it's usually better to err on starting low. And I typically will start patients on between 6 and 12 units twice a day. So 6 units twice a day will be about 12 units, and watch the response and then increase. There's no need to start with very high doses. I'll also tell us that many times when you're starting this stuff, patients make more dietary changes because they now say that, so this sugar is enough for doctor to want to start me on this. They make more dietary changes, and the dietary changes can charm your insulin, and then you now see the person actually, the sugar setting pretty low on time, and you don't want them to have hypoglycemia. Okay, you can also do a basal bolus regimen with basal about 0.2 units per kg per day with some prandial insulin. But in patients that have predominantly fasting hyperglycemia, so that is the 2 hours after food and 1 hour after food, is actually fine. It's just the fasting that is predominantly high. For many of those, we can actually get away with just a basal insulin, which is way more convenient for the patient, requires less intensive monitoring, risk of hypo is much less, and convenience is actually really prime. So we can do something like the determined insulin or the MPH and give out that dose once in their bedtime. Typically, you start around 8 to 10, except in people who have higher weights or have a higher degree of dysglycemia. And then in those, you could start at a higher dose. But whichever dose you start with, monitoring is key, patient education is key, and we should be flexible, willing to adjust rapidly. So usually we titrate the doses up by about 10% every 3 days until you meet the target. So let's say I start someone on determined insulin once daily, or let's say we start someone on Novomix insulin twice daily, and let's say giving 8 units in the morning, 8 in the evening, that's a total daily dose of 16. So that means every 3 days, if the targets are not met, I can increase just by 2 units. 10% of 16 is about 1.6. Okay, it just increases every 2 days. I can teach the patient to do this actually, and when it meets a certain target, they maintain it. But most people eventually tend to require between 0.5 and 2.0 units per kg per day. So I think that's about it. And if you have concerns in starting or deciding the dose, I think you can just call one of the specialists, doing cardiac care, and then we can give you an idea of what you can do to in terms of starting the patient on those doses. Now, oral agents. So use of oral agents in gestational diabetes has been controversial.
Actually,
it has been controversial, but I think we are learning more and more every day. So as at like maybe 8 years ago, virtually everybody I knew with pregnancy is just absolutely everybody was on insulin without exception, actually. Okay, but more recently we're having more data on safety profile, and increasingly it's being used as a first-line agent for maybe mild to moderate glycemia in pregnancy. I know that the NICE guidelines favors use of metformin first, whereas the ADA, that's the American Diabetes Association, still tilts more towards insulin, and they're quite wary of that. Okay, but we know that the US is a capitalist economy. So metformin has lower risk of hypoglycemia compared to insulin and other oral agents that has been considered. You have less maternal weight gain, which is possibly a pro. Unfortunately, it crosses the placenta, but it is not teratogenic. Okay. Unfortunately, also we don't have robust long-term data on offsprings of people with whose mother took metformin while they were in the uterus. There are some concern that it's associated with childhood obesity, but we should put in mind that GDM itself and diabetes itself is associated with childhood obesity. So we have macrosomia and also childhood obesity. And but it has a role, especially for women who find insulin unacceptable or they are unable to use insulin safely. So some people they find it unacceptable, but they don't have something to monitor weight, they're not so literate, they can't understand the dosing, and then the chance of something nasty happening is just quite high. It's probably better you just put the person on an oral agent. People have also used glyburide, that's the benchmark in pregnancy, but I have not really had any experience with that. And but there's a palpable risk of hypoglycemia when these agents are used in pregnancy. So I think I'll just be a bit cautious of that. Before we go further, I just want us to look at this chart. Unfortunately, it's very tiny, we will not see it so well, but this is a study published in BMG that actually compared glucosamine, metformin, and insulin in the management of GDM. Okay, so it's a systematic review and meta-analysis. And I think one of the key findings that we have there is that metformin actually, in the second chart, I think you can look at it when you get the slides later. It's not coming out very boldly on the screen. Okay, but the metformin actually performed fairly favorable compared to insulin in terms of weight gain, hypoglycemic episodes, baby's weight, that's fetal weight. Metformin actually performed quite good. Again, the concerns about metformin is in terms of efficacy. That is, if the degree of dysglycemia is very high, metformin alone may not be able to act, may not also be able to act on time if we eventually act. That's one. But second, and more important, is the concerns of the unknown feature. There's data of up to about maybe 7-10 years, okay, but it's still not robust enough to give us the confidence enough. And I think they summarize that comparing short-term endpoints in women with gestational diabetes requiring drug treatment, metformin plus insulin when required, I will talk about that, performs slightly better than insulin. And according to this result, glyburide should not be used for the treatment of GDM because of risk for hypoglycemia and because of other factors as well. Okay, but metformin when required actually performs as good as, or at least maybe even slightly better than insulin. Now, the catch is that for many people that are offered metformin for their GDM control, for the glycemic control, many of them will actually require insulin along the line. That is, metformin will actually fail many of them. That's the truth. Now, some people refer to it as fail. Okay, but again, is for those people, I consider it as about moving from diet and lifestyle to trying drug and then to giving insulin if any of those above is inadequate to use. Okay, but it's important to recognize those patients that you need to start outrightly on insulin, because the longer we expose the baby to dangerous glucose levels, the worse the pregnancy outcomes. What's your own experience been with the oral agents and insulin in pregnancy?
Actually, from my little practice, I in using more of insulin.
Absolutely. And I think that's globally actually more people are on insulin than metformin. It's just that the amount of people that are being tried on metformin is increasing, is gradually increasing over the years. Okay, but I think the more we use, the more we learn about it. Now, talking about monitoring, monitoring of people who have diabetic pregnancy is perhaps the most intense part of the treatment. And it's critical even when patients are not on medications. Patients struggle to understand it. They were like, well, doctor, why do I have to be checking this thing 4 times every day? Okay. Unfortunately, the glucose tolerance in pregnancy actually can change fairly fast. And then it's predominantly postprandial issue. So checking fasting alone is grossly inefficient. You may not even catch it at all. By morning, the glucose has normalized. Okay, so the patients usually need to do daily 4-point glucose profile. For people not on insulin therapy, sometimes you can relax, particularly if you've seen a clear pattern. Okay, but ideally should be checked daily 4-point glucose profile in pregnancies. And the requirement for treatment often increases as pregnancy progresses. That is, someone that is controlled on diet and lifestyle. By the time person now was controlled on diet and lifestyle at 24 weeks, by the time person gets to 32 weeks, person may be requiring insulin, for example. And if you're not checking, you will know that you lost control of this. Okay. Also, patients have, it's just human actually, it's a human tendency to not check after some meal. So when the person eats something quite nasty, maybe they ate a big bowl of rice and follow it up with ice cream, they won't check their sugar after. Okay, so but by the time you compare the patient to be checking consistently and they see the food, because it actually reflects the glycemic index and load of the food, they see it clearly. They know the food items they should not be eating again, they know the one that should reduce the amount, etc. Okay, it's important to titrate insulin like we talked about, and there's increasing use of continuous glucose monitoring in the Western world. Unfortunately, such technologies are not really available here. I've seen a few patients with it, but most of them, but all of them got it from outside the country actually. So the liver flash device, the Medtronic guidance system, and all of those things. But they help in pregnancy, and they make some data actually shows that the fetal outcomes are slightly better compared to by the time people with type 1 diabetes. Okay, so these are the glycemic targets. We know that for people with type 2 diabetes, for example, fasting targets is usually traditionally less than 110. More recent ADA guidelines quotes less than 130. But in pregnancy, the target for fasting actually should be less than 95 or less than 92. Okay, and that's quite stringent. Okay, so you need to push your patients on your patients is able to achieve this. Of course, we don't want to cause any hypoglycemia, and you don't want to cause any morbidity for the patient. Now, the postprandial, you need the glucose to be less than 125, and we can see that that's quite stringent. Okay, so these targets should be met. And if you're not meeting the target, it means that you need to intensify and upgrade whatever you are doing. Okay, either you're adding medications after you're or you're increasing dose of insulin, you need to be doing something different so that the targets are met. And it's important that we do this because, like I tell patients, when, God forbid, if we end up having negative pregnancy outcome, you blame yourself and the patient will blame you. But when you saw that my sugar was not controlled, and then or you didn't do anything extra about it. Exactly. So we need to be seen to act on it, and then we cannot just watch. We cannot watch again. When the patient did A the last week, and they are saying they should do A again this week, they're going to get the same thing. So we need to upgrade whatever we're doing so that we get the results that our patients. So I've talked a lot about the glucose monitoring. So now we'll focus on the obstetric point of care again. So we talk about the antenatal management earlier. So as this patient is getting towards term, what are the other key things to consider?
Usually, as patient approaches term, you need to evaluate patient and plan her delivery.
Right.
Ideally, we aim at vaginal delivery,
right,
except if there's contraindication to vaginal delivery, then we can go for cesarean section. And usually we aim delivery to be between 38 to 40 weeks. But most of the times we don't want them to exceed their expected date of delivery.
Oh, yeah.
Yes, because of the morbidities that are associated after their EDD.
Right.
So usually various modes of delivery can be spontaneous labor. They can go into spontaneous labor, or perhaps if they have, for any reason, there's obstetric indication, or however, if they're extending or the pregnancy is going beyond their expected date of delivery, you need to evaluate them. And if there's no contraindication to vaginal delivery, you can admit them for induction of labor.
there's a common saying that I've heard several times. So women will tell me that they said that once there's diabetes in pregnancy, it is yes.
No.
It is yes. So there's no truth in that.
There's no truth in that.
Right?
Usually we try to aim at vaginal.
And that's the whole aim of managing. I mean, that's part of the aim of managing diabetes in pregnancy very well. If you can avoid fetal macrosomia, the threat of shoulder dystocia and core will not be there, and then the chance of you having preeclampsia and other issues is much less, so that we can actually avoid unnecessary surgical delivery. What are the other common things we consider in the perinatal management?
Usually when they come, by the time they come, they need to evaluate as they approach their EDD, evaluate this patient, do an ultrasound scan, try to do estimated fetal weight to estimate the weight. Usually if there's fetal macrosomia, when there is a estimated fetal weight of greater than 4 kg, or America use 4.5 kg. For such patients, you need to start counseling them for abdominal delivery because it is safer, because there's increased risk of shoulder dystocia. Also, you have to ensure that their sugar level is well controlled. Yes, and you aim at delivery between 39 to 40 weeks, usually, because we know that for patients with diabetes mellitus in pregnancy or gestational diabetes, there's usually delay in lung maturity. And as such, yes, actually. So you delay their delivery to anything from 38 weeks to 40 weeks to ensure that there's already matured fetal lungs. Yes.
Okay. So we said earlier that vaginal delivery is preferred in the absence of other obstetric contraindications. Now, in addition to that, the insulin requirement during intrapartum period, that's talking of intrapartum now, depends on the diabetes control, which is true. And there are ways to assess this. But mostly, people who had good glycemic control in pregnancy, particularly on diet and exercise only, they don't require insulin in the peripartum period, because you just check their glucose and it's just so controlled and they just have CS as normal. Okay. People who also require low amount of insulin, I'm not sure whether this value is very accurate, but people that require typically less than 20 to 24 units per day, generally not per kg per day now. Usually they are unlikely to require peripartum insulin infusion. But in people that require anything more than that, usually they require. And usually the people that would likely require, you tend to know. Okay, so it just depends on the extent of insulin resistance again. So by the time, usually, I'll go into it a bit in the next slide, but we know that if there are clear written protocols and guidelines that's center specific for management of perioperative management of GDM women on insulin, it improves the outcome actually. So I encourage us in our center, to manage the GDM women that sometimes they will have CS and they will have insulin before delivery. I think I'll try to share a protocol sometimes later. Okay, most women will be admitted electively either for induction of CS, even though of course a lot of people will just continuously fall into labor and then they would have a so-called SVD. So the peripartum planning. So on this slide we said here that they take their normal insulin dose the night before or oral medication the night before. Okay, but on the morning of the surgery, obviously they don't take anything. We try to make the surgery early. I think we said that earlier. And of course, the patient, the neonatologist should be carried along as well, because there's a slightly higher risk for
respiratory distress syndrome.
Absolutely, hypoglycemia and all the other work. So the neonatologist should be carried along. Okay, so on the morning of the procedure, usually we check the glucose hourly. So they check hourly. And if the numbers are within range, we don't need to give the glucose insulin infusion. But by the time you're getting numbers above 110 or above 120, okay, you probably need to start your a GKI infusion. Okay, just your aim is to keep the sugars between 80 and 110. Now, people find this a bit, people would struggle to understand this number. So, yeah, you see someone with a glucose of 120 or 125 or 130, and I say we should start the GKI infusion. No, it is necessary. Why? Because keeping the glucose within this range I specified, it improves a lot of things, the CS morbidity, and even how likely you are likely to get fetal hypoglycemia and all the other issues is less. Okay, so we should be mindful that in GDM we want to stop insulin infusion as soon as the placenta is delivered. Why? Because most of the hormones that are countering insulin action that are causing insulin resistance. They are actually placenta-related hormones. So once placenta is out, the serum concentration of this will rapidly fall, and of course, the patient is prone to having hypoglycemia if you are not very attentive. So insulin infusion, but of course, you continue your glucose monitoring because you can have either hyperglycemia, you can also have hypoglycemia, but it's more of hypo we're watching for. In people who have pre-gestational DM, in which you know that this person actually had diabetes before pregnancy, again, the insulin requirement reduces because we know that the placenta hormones act to some insulin. Exactly. So we need to reduce insulin proactively and then monitor. Sometimes we need to raise a bar. Most times you probably don't have to. So what do we need to do after delivery?
Usually after delivery, more importantly, you need, especially for the first 24 hours, you need to monitor the serum blood glucose level.
Absolutely.
Very well. And also, usually following delivery, for the babies especially, you need to be on the watch out because they are prone to hypoglycemia and also dyselectrolytemia. And as such, you need, if possible, if in the presence of a special care baby unit, this baby should be monitored there so that blood sugar can be monitored closely.
And if there's any issues, speak on time.
Yes.
Absolutely.
So usually for the GDM, just like you mentioned earlier, the glucose drops following delivery and the delivery of the placenta. And as such, you just repeat your OGTT at 6 weeks postpartum.
What proportion of patients come for that 6 weeks?
Yes. Usually in our environment, usually for normal vaginal delivery, cesarean section, we give their appointment at 6 weeks. Some you lose them to follow up. But ideally, many times they do stay calm.
I put this in that fasting and 2 hours postpartum are often surprises. This may usually have a glucometer, sometimes they check on their own. But is there any advantage of doing the OGTT at that time rather than just them checking with their glucometer?
Actually, like in my practice, sometimes you do your fasting blood sugar and 2 hours postpartum, it may suffice. Actually,
it may suffice actually. Even though the OGTT is more sensitive, and it's more sensitive, and then, but usually it's also important that these people continue to monitor for diabetes long term, either every 6 months, every 1 year, to every 1 to 3 years. Okay, and then the lifestyle. I encourage them that the lifestyle changes they adopted in pregnancy, they should continue to imbibe it. So they should get used to taking vegetables with all their meals, the carb portion should be controlled, and all of those advice are things that we encourage them to continue to adopt long term. What about for the baby? What extra do we need to do for the baby?
Usually for the baby, just like you said earlier, instituting breastfeeding, oral feed is very, very important. What I would say, they are prone to hypoglycemia. There's this story that my teacher once said. It was in the general hospital. They just delivered a microsomic baby, and all the family members and all that, baby was just in the cot, just lying quietly. To them, they felt, oh, baby is just just sleeping, not knowing that for this baby that microsomic baby is prone to hypoglycemia. Unfortunately, they lost the baby to hypoglycemia. So you need to be on the watch out following delivery. Close monitoring of the blood sugar is very, very important following delivery so that to avoid hypoglycemia. Institute breastfeeding as early as possible. And when that is not feasible, you can even give dextrose containing to the baby before establishment of breastfeeding.
Now, talking about breastfeeding now, you mentioned to me when discussed earlier that people who are breastfed actually have a lower risk of developing diabetes. Okay. Is there another particular considerations we need to make for breastfeeding?
Yes, for breastfeeding, because first, breastfeeding itself is energy demanding. So before instituting breastfeeding, it's advisable that there should be food intake by the mother, so that before proceeding on breastfeeding, calorie intake should be increased to accommodate breastfeeding during that period. And we have to ensure good hygiene so that they will avoid any source of infection during the course of breastfeeding.
And in terms of medication, metformin is safe in breastfeeding. Insulin is also compatible with breastfeeding. Remaining oral glucose-lowering agents, a bit of uncertainty, but definitely the DP4 inhibitors should not use. And many of them, so you probably should stick to. And of course, we've managed many people that just metformin. If it's not enough to control the glucose, these are usually people that are pre-existing. You need to add insulin to it until they are done with breastfeeding, just for mostly for safety reasons. So I'm not sure we talked about this complication so much earlier, but basically the complications in the mother include infections, preeclampsia risk, preterm labor, they can have DKA, they can have vascular complications of diabetes, both macro and micro. There's increased chance for operative delivery. They can have genital tract injuries because of the baby, or because of shoulder dystocia. They also have a high risk of PPH, and then the long-term risk of type 2 diabetes is there. Complications in the baby includes risk of miscarriages, particularly early in pregnancy. They can be big macrosomia. They can have congenital anomalies, also all sorts of that. There's higher chance of birth asphyxia. You talk about IUGR growth restriction earlier. There can also be fetal deaths. They can have birth injuries, so shoulder dystocia. They can have metabolic disorders, including diabetes, hypoglycemia. Diabetes long term, but short term, hypoglycemia, hypocalcemia, low magnesium. They can also have polycythemia, from what you mentioned earlier, the hypoxia, triggering all these other things.
Protein production.
Absolutely. And there can be long-term complications like type 2 diabetes, childhood obesity, cardiomyopathy, and cognitive impairments. I think we talked about this. There needs to be long-term follow-up before. Absolutely.
Both for the mother and for the baby.
Absolutely. Especially for the mother. I'm not sure anybody follows up the baby apart from research, but it's important we start doing these things actually. So family planning is also important. It's important for every woman to be able to plan, especially those who have pre-existing diabetes.
And even other medical disorders.
One of diabetes in pregnancy pre-existing diabetes pregnancy is not easy. Actually, it's not easy at all. Okay, so someone has been using tablets, has been managing herself for so long, and just now got pregnant, has to move to insulin, has to gain more weight that they've been trying to lose before. So that happens. There's someone I have currently that I'm managing. She was actually a unplanned pregnancy. She already has 4 children, but she has the 5th. She's in her early 40s, and then she just has the 5th now, and then she's very heavy. In fact, she was so ashamed to come, and she didn't come until she was in the 3rd trimester. So, anyways, we should discuss family planning with our patients with diabetes, and there are many methods. I think usually in the gynae clinic, we should be able to find the method that most suitable for the patients. Exactly.
For those that have completed their family size, we'll discuss, permanent methods such as bilateral tubal ligation or vasectomy.
Right.
Then the progestogen-containing contraceptives are also suitable for them, such as progesterone only pills, or even the implants are also suitable for them. And intrauterine contraceptive devices are also suitable for them, although those oral contraceptive pills. Yes.
Okay, so just as a summary, just a overview. People that are high risk to have a fasting blood sugar can have a fasting blood sugar early in pregnancy. If it's normal, you can delay and do your OGTT at 24 to 48 weeks. If it's abnormal, ask yourself whether it's pre-gestational. Of course, further evaluations is necessary as well, and of course, the criteria for diagnosing our GTM is fasting, 1 hour when they do it, and 2 hours. Any. If any is abnormal, it is GTM. Okay, and if any of the criteria exceeds the criteria for diagnosis of diabetes in pregnancy, you should make that diagnosis. So once there's a need for management, someone someone that has GTM or DM in pregnancy is better managed in specialist setting with an endocrinology and with a gynecologist obstetrician. Absolutely, that's interesting. So in conclusion, I'll conclude by saying that diabetes is more of a bigger issue in pregnancy now, particularly with older age of pregnancy and increasing obesity. We know that if we control the glucose poorly in pregnancy, it increases problems for both the mother and the fetus, and the risk of adverse outcomes is much higher. So it affects us as a practice. It also affects the health indices of the country. We know that Nigeria is one of the worst maternal mortality data at some point. Okay, so now we have more standardized screening methods. So the diagnosis and the management is going to be improved and it's going to be more streamlined. Okay, but we should put in context, long-term risk for both the mother and the baby, and then that means we should do more in following up of our patients. So I think we'll take some questions now.
Okay.
Let's look at the Q&A box now. Please, if you want to ask a question verbally, I'll suggest that you raise your hand up, and I think I'll promptly. Okay, so I'm trying to look for this. I'll promptly respond to that. What's happening? I'm not getting the mouse to work. What's happening? Just hold on. So I'll take the questions now. Okay, so I got it. I think you just want to sleep or something. Okay, so we've got the questions now. So I will start with Amos. Okay. So I'll just go through the first and we'll scroll all the way down. Okay, so first question I can see here is okay, what are the values for GDM? Are we using fasting blood sugar or OGTT thing? So in terms of making a diagnosis for gestational diabetes, the standard to use is an OGTT, not just a fasting. But we should not forget that in OGTT, there's a fasting, there's a 1 hour, there's 2 hour. That's in a 75 gram that we do. But some people have the other one that has up to 3 hours. Okay, so you need OGTT to diagnose GDM. Okay, but of course, if any of the parameters is abnormal, including just the fasting, you can make a diagnosis for GDM. But put in mind that if that fasting exceeds the cutoff for diagnosing routine diabetes, that's over diabetes, if it exceeds 126, then it's not GDM again. It's overt DNA pregnancy. So that's important. Is there an indication for Doppler scan? If yes, when?
Yes, there's an indication for Doppler scan. You can do a Doppler scan towards STEM.
Okay. What exactly are we looking for with the Doppler scan?
Yes, Doppler scan, especially when you are suspecting, there are some, by the time there's maybe complications, you are suspecting that complications are setting in, such as intrauterine growth restriction. Okay. By the time you do your fundal height, and you think that it's less than the expected gestational age, you are already suspecting intrauterine growth restriction. So you can request for Doppler scan. Okay. And also when there's also coexisting hypertensive disorders, pregnancy, also request for Doppler scan. You want to assess, the whole essence of Doppler scan is to assess the placenta sufficiency. If perhaps there's good supply of blood supply or is impaired, so that you help you to determine when to effect delivery.
Absolutely. Thank you very much. And that goes to the next question. That was the ideal EGA for delivery. I know that some people try to say that they want to deliver slightly earlier because of the risk of IUFD and all those things. And then some people want to deliver slightly later because of respiratory different and lack of lung maturity, so to say. So where is the middle point where she will meet? So what would we say is the ideal time to deliver?
It has been recommended between 39 weeks to 40 weeks. Because just like we said earlier, the fetuses of babies, of the mothers with diabetes in pregnancy or gestational diabetes, they can have delayed lung maturity. And as such, you have to put that into consideration. You have to ensure that the babies, the lungs are well matured before you bring these babies out.
Can that be accessed prenatally?
Yes, it can be accessed prenatally. It can be assessed prenatally.
That's right.
Yes.
That's right. Maybe we have another question between 39 and 40 weeks. Yes. So the next question is that someone asked, is there any oral agent licensed for use in pregnancy? Now, license is a very big word, okay? And at this level of discussion, something will not wait for licensing in court, so to say. Okay, but we discuss what the guidelines say and what the research say first of all, and then what the guidelines suggest. Okay, so we have research for insulin, metformin, and also for glyburide. Glyburide, the overall evidence and data suggests that it's not worthy to be tried to use. It's not worth trying to use because risk of hypo is there, but it can be used actually from some studies. Okay, insulin as data is licensed. NICE guidelines UK recommend that you should use metformin as your first-line medication actually for diabetes in pregnancy, even though the ADA says a bit otherwise. Okay, but in terms of the medication itself being licensed, well, I'm really not sure which one. It depends on who is licensing, whether it's FDA or NAFDAC. But I'm not sure of the licensing part. Okay, but that's what the research says, and then that's what the guidelines suggests as well. Okay, so looking for the next question here. Someone says here that oral glucose tolerance test is more sensitive than fasting blood glucose alone. Yes, absolutely, that's true. It's way more sensitive because particularly in pregnancy, not just GTM, actually, it's more of a postprandial issue. You need to expose the person to a glucose load, which, thank you, that challenge, that dynamic testing is necessary. So, fasting blood glucose is not a good screen for GTM at all. Someone asked again, like, is metformin safe in pregnancy? So, like we did show from the meta-analysis published in that BMJ, if safety in pregnancy is not so much of a concern, it has been shown reasonably to be safe in pregnancy. What we don't have enough information on is actually the long-term effect on offsprings into their teenage years, into their whether it causes something or something like what we don't have enough data. Okay, but the short-term benefits in pregnancy actually, from that meta-analysis I showed earlier, it's actually sort of outperform insulin. But again, don't forget that in people in which you ask to use metformin, you should be open to using insulin, either switching to insulin or adding to it if you're not able to get your glycemic control. And I'll tell you that for perhaps more than 50% of who you attempt to use metformin for in pregnancy, more than 50% of them will not actually be controlled on metformin. Not control of it. Okay, so where are we now? Please, what's the cause of IUFD in GDM? Person did not get the explanation you gave earlier, sir.
Okay, for IUFD in GDM,
right.
In some instance, just like we said, there could be micro or macro vascular complications that could set in.
Right.
So when there's vasculopathy setting in, there's reduced blood supply to the placenta,
right,
and eventually blood supply to the baby.
Right.
So gradually intrauterine growth restrictions.
Absolutely, and it can lead to death. Okay, someone just commented and suggested that the WHO, so based on one WHO classification, that it's preferable to use the term hyperglycemia in pregnancy. That's fine. One can call it hyperglycemia, but I think diabetes in pregnancy is just very clear, and we are aware that we're dealing with a disease, and that because it's actually diabetes in pregnancy, GDM is classified definitely under diabetes, and is a sort of hyperglycemia that is able to cause harm. So leaving it as hyperglycemia alone, I think it's sort of ambiguous. Okay, how do we assess fetal lung maturity in these fetuses? Okay, so that's a question for you. How do we assess fetal lung maturity?
Okay.
Without going into more details. So.
Okay. Fetal lung maturity can be assessed. There are some things you can do. You can assay sphingomyelin or lecithin.
Right.
By the time you do the ratio.
That's it. That's an analytic.
Yes, pure analytic.
That's very invasive.
Yes, it's very invasive.
So there's no surrogate thing that can be done.
Yeah.
There's no pattern on CTGs or something that can. I know that this fetal lung is not immature.
Many times it's invasive.
Right.
Yes.
Right. Well, I'm not sure anybody will have. I won't agree to that. Okay. So to lessen the risk of IUFD, can any medication be used? I will answer that. I mean, from my perspective, I will let you add on anything. So the most important thing we can do as physicians to lessen the risk of IUFD is to control the glucose extremely well. The better glycemic control you attain, the less the pregnancy complications, including IUFD. So we have that from the studies. And the case report I gave earlier at the beginning of the presentation, the person's IUFD is mainly predisposed. The person has the unrecognized, undiagnosed, and untreated diabetes in pregnancy. So if we get euglycemia as much as possible, in fact, out of all the complications we are trying to avoid, I think IUFD is the most notorious one that you really want to avoid. Now, it is emphasized, and it's stated just like that in the NICE guidelines as well, that we should emphasize to patients that the risk of these things can be reduced. It cannot be eliminated, because even a perfectly normal human being can have IUFD, so to say. So it can really reduce the risk. Okay. Someone is asking here. Someone states rather that hyperglycemia in pregnancy is divided into diabetes-induced pregnancy, not sure what the person said, DIP and GDN. Maybe you can restate it sometime somewhere lower there so that we can just discuss that and rub minds on that. But I know that it can be pre-gestational or it can be gestational diabetes. So someone said, what's the cutoff point for commencing insulin in GDM? That's a very good question. The way I will answer that is that there are two approaches, or three, but let's say two approaches to making that decision. The first is that no matter what extent of numbers you are getting, if you are doing non-pharmacological therapy and the person is not meeting targets, you need to go to pharmacological therapy. The pharmacological therapy, the preferred is insulin. So that's one. Second approach is that if someone that you were not meeting targets with non-pharmacological approach before, and then you started metformin in such a person, and you're not meeting targets. Target is getting way above 80% of the readings. The person must be doing a daily 4 point at least. Way over 80% of the readings must be within target limits. If you're not able to really get virtually most of the readings within target limits, then you need to step up to the next level, which is insulin. Now, the one that is perhaps the most difficult are the ones that you need to start insulin outrightly without doing any lifestyle alone. Now, the person will start lifestyle, but you're starting insulin right there and then, okay? And by the time you're getting overt hyperglycemia, for example, you're doing your OTT and you're getting fasting, the rate exceeding 110, 120, you're getting postprandial exceeding 150, 160. There's only very little we are going to achieve. We are not likely going to meet glycemic goals with diet and lifestyle alone. I know if you're almost going to, the amount of the duration of exposure you're going to put the fetus to is high, and then putting in mind that insulin resistance increases as pregnancy progresses, you know that resistance is still going to be worse along the line, and then so I think those three groups are the ways usually in which insulin is started. We mentioned earlier that for overt diabetes in pregnancy, one should actually go straight to insulin because you're not going to get anywhere near control with just diet alone. How safe is metformin in first trimester in people with pre-gestational DM? That's a good question. So again, the safety depends on what we're talking about now. In terms of safety for pregnancy outcomes, the data that exists suggests that it is safe. That is one. That's in terms of short-term pregnancy outcomes, controlling glycemia. Now, how likely is it to be able to control the glucose by itself? It's very unlikely for you to be able to control glycemia with just metformin alone in pregnancy, except if it's a mild degree of dysglycemia, maybe the person was just on diet before pregnancy. But for a pre-gestational DM, it's very likely the person requires insulin in pregnancy. Now, again, the safety concerns of metformin is what we have discussed, okay? And what we discussed about the safety concerns of metformin is that there is lack of robust long-term data, especially on the offspring. So long-term data is talking of 5 years, 10 years, 20 years. So the data that is existing is not robust. Already, we know that some studies suggest that there is a tendency to childhood obesity in people, but it's a tendency and it's not just clear. So we just need more data. And we know how we do scientifically. If we don't know too much about something, we probably want to err slightly away from it when we can. In terms of the dosage of insulin in GDN, I won't be able to go into too much details now, okay, but usually we start small and we climb up slowly. For the vast majority of people you need to start on insulin, you're going to start them either on twice daily premix insulin, which will be easier to use, preferably the analogs, or we can do a basal bolus regimen, which will be dosed the way I phrased it earlier. For the twice daily, for the basal bolus, you are more likely to do 0.2 basal. So in a 60 kg woman, for example, 0.2 kg will be, what's that? That's about 12 units of basal of your MPH or your Lantus, or your Detamir, and then about 0.1 per unit per kg per mil for the prandial, okay? That's usually just a starting point, but you will escalate, you'll adjust every few days. Now, that starting point sometimes, in fact, every time is influenced with the ambient glycemia at that time. So the way I will start someone, irrespective of the weight of someone that has a sugar of 120 or 130 fasting, is different from the way I will start someone that has like 160. You understand what I mean? So the ambient glycemia at that time too will influence with the dose we use, okay? So I think that's important. And then sometimes how prone the person is to hypoglycemia and how well the person is able to monitor and safety concerns, and we can also influence your starting dose as well. There's a question here. in view of hemoglobin physiology, does it mean that A1C has no place in pregnancy at all? I would say negative to that, actually. I do agree that A1C has a good place in pregnancy, even though we are understanding the place more and more and more over time. I routinely do A1C for people in pregnancy, and we do have some research on that that was published earlier on. That's from Cardiac Care. So A1C, as it gives you some idea. Thank you very much. And we did say earlier that in people in which the first trimester you check the A1C, you're getting about 5.5, 5.7, it's likely that person will get GDM. First of all, if you have someone that you're managing for GDM and you're getting your A1C greater than 6.0, it's likely that it's not well controlled. Okay, so you can just transpose it to A1C outside pregnancy by subtracting 0.5 to 1 from what you put the A1C. So you just have that dilutional effect in your mind. So I think that's just it. So the reason why it's important to have another surrogate to check is because someone is at home and the person is checking, what if the glucometer at home is 40, for example, and then they're just getting reasons that are off. You need something that can just highlight you and say that this person is not likely controlled. So it's just something to give you double sure, to make you double sure, and then you can see something from another angle as well. And of course, we have studies that show that the A1C2 has some correlation, even though it is somewhat inferior to SMBG in monitoring. It is definitely inferior, actually, because you need your SMBG, that's the day-to-day glucose monitoring, to make day-to-day changes and titration of the insulin regimen. Okay, so someone saying here that in turn, how is the nutrition for GDM patients? Is there any food that they should avoid? Yes, people with gestational diabetes or diabetes in any form should avoid grossly sugary food, okay? But otherwise, it's more of controlled, balanced diets. The amount of carbohydrates should be controlled. They should not give in to their cravings. And of course, they should try to take a healthy portion of protein and vegetable with their carbohydrates. So, but it's individualized. So, the food I would say generally that they should avoid are things that are grossly sugary. So, ice cream, sweetened beverages, etc., etc. They should probably generally avoid those. Okay, but they can eat the regular food. But again, it is exquisitely sensitive to food. So some people do a trade-off sometimes. Rather than starting insulin on time, they deprive themselves so much of calories sometimes, which is not a problem for me as long as they're not getting ketotic, one, and that they're not failing to gain the appropriate amount of weight they should gain in pregnancy. Okay, but it's better to put on just a healthy amount of diet, and usually it's best done by a nutritionist, and then give them the medication when they require it. So I think that would be a good balance for them. I really appreciate, I think it's been a wonderful discussion.
Thank you, sir.
Yeah, so it's been a wonderful discussion. Thank you for being part of this discussion. Thank you for listening. I think the questions were very interesting and they're engaging. And I think I've learned quite a bit from this discussion as well. So I think that's very good. Do you have any final words, Dr. Amos?
Yes, just like we said during the introduction, that gestational diabetes mellitus is one of the disease entity with a lot of, as well with increased perinatal and maternal morbidities. Sometimes even mortality. And as such, it's very important for early diagnosis and institute appropriate management, favorable fit out.
Unfortunately, too many people we're still having too many bad outcomes from diabetes-related pregnancy. I've seen too many. I can count like 5 to 10 on my fingertips. So I think we can all together do better for our patients. And I think so. Once again, this presentation is coming from Cardiac Care Multi-Specialty Hospital. We focus on cardiology, endocrinology, neurology. We have an ICU, and then of course we do interventional cardiology procedures, including coronary angiographies, percutaneous coronary interventions, stenting, angioplasty, even peripheral arterial interventions. There's someone we're managing currently for diabetic foot. The foot was almost going gangrenous, and we managed to save the foot. I'm just waiting to have the pictures at about 5-6 weeks before I published and circulate. So it's really beautiful. The toe went from being quite dusky, and the toe is now pink, actually. Okay, so we do all of those things, and I think we believe in that rubbing minds with each other improves each and all of our practice. So hopefully from this discussion this afternoon, we all can up our games and our population will be better for it. So thank you very much once again. Sometimes next month we'll be discussing another interesting topic and I will encourage us to join. Thank you so much.